I'm a general internist, so I see patients in primary care, and I'm going to tell the story of Ms. P. So I know Ms. P had a hard life from the beginning. I met her after what should have been a pretty routine appendicitis surgery. But nothing about Ms. P's course and nothing about her life was really that routine. She came to see me with ongoing pain after her surgery, and further workup revealed that her pain actually was caused by appendiceal cancer that was discovered after her surgery. And as she recovered, I got to know her pretty well. And what should have been something simple and routine like appendiceal surgery really wasn't for her. And as time went on, her course was complicated. She had lymphedema, so she had swelling kind of all over her body. And she had chronic pain in her belly, which made it hard to eat. And so I saw her frequently, and her visits to the office were never simple. All right. We have a lovely front desk staff, and probably our nicest, most efficient, and most even keeled office staff member was pregnant at the time. And this patient, Ms. P, was so challenging and got so upset that our nicest, most even keeled front desk staff member actually went to the hospital with hypertension during pregnancy because of how difficult and how agitated she became due to this patient. Ms. P was so challenging when she came into the office that my office manager at the time, unbeknownst to me until she told me afterwards, would wait in the room next door, make sure it was vacant, wait, and when things got particularly heated and she heard yelling coming from the room, she would knock on the door and very swiftly and kindly sort of save me and de-escalate the situation. And she just knew from dealing with Ms. P and kind of working with her that this was a patient who required a team-based approach. And much as it was challenging to work with Ms. P, she was endearing, and she was, I got the sense there was more to her story. And gradually she opened up one day when she mentioned that she was feeling really fatigued. And I asked her, how are you sleeping at night? And she finally started to kind of get some tears in her eyes as she told me that sleeping was tough because she was sleeping on the bus because she didn't have anywhere to go home to. And gradually her story unfolded from there, that she was estranged from her kids, that she had a husband who had been abusive in the past, and that now her circumstances were complicated by fear of her ex-husband, by homelessness, by food insecurity, and by these chronic medical problems. And once she kind of opened up and told me what was going on in her life, not only was I think, more able to respond to her needs, but I think I was more sort of patient and able to be the kind of doctor that she needed. And I think our whole office staff was really better to able to help manage some of her ongoing medical problems and some of her ongoing social problems. And I think, the story taught me that we in medicine, like everybody, are quick to judge and often don't give people the benefit of the doubt and often don't know the whole story. And only by getting to know people, which is challenging with 20-minute office visits and competing priorities, to really get to know people and kind of what's behind them. Only by getting to know people can we really see them as the whole people that they are, and really start to work with them, meet them where they're at, and work together to help them with their health goals. I think the other thing that the story taught me was just how much you need a team-based approach, right? The even-keeled front desk staff member couldn't do it by herself. I certainly couldn't do it by myself. And my office manager was the one who had to step in and kind of help things go smoothly. And so I think it really takes a village to help every visit and to help every patient. And, I think she taught me the importance of being a better history taker and just sort of being patient and letting people's stories unfold to you over time. So I appreciate the chance to share the story of Ms. B with you.
So in prepping a story for tonight in which I felt the strive for health equity applied best in my experience as a resident, I, as someone who wants to go into primary care, of course, was thinking about my primary care resident clinic experience. And as can be stereotypical for resident clinics in all specialties, we do tend to see patients that are generally economically and or socially disadvantaged in some way, on top of being quite medically complex. So in thinking back to the beginning of my intern year to my experience now as a third year, I realized how even in that couple of year span, there have been some significant changes. In particular, as residents, we used to only do traditional clinic visits where patients come to the office for their appointment. Within the past year, however, there has been a big change in the way we see patients, and that is by taking part in home visits and telehealth visits. And not only just occasionally taking part in these, but the fact that these are now routine and standard for us as part of our clinic experience. And so my story describes my first home visit as a resident. So the patient I saw with my attending, we'll call it patient Miss R. She was an elderly disabled female living alone in dorm style housing. She had a daughter that came to help her after work, but otherwise had no family or close friends to rely on for help. She wasn't able to drive, had no other family to be able to drive her to clinic as her daughter worked during the day. She couldn't afford private transportation. So we finally had the opportunity to see her at home, which she was delighted about. And at first, it was really strange for me. I felt like it was an invasion of her privacy for me to be in her home. But as the visit went on, I realized how helpful being there was for both me as a provider and the patient. As a provider, I felt like I could gather so much more information that I may not have necessarily gotten from an in-office visit. We were able to view her ambulate with her walker around her house. We counseled her about several tripping hazards that we noticed. We noticed she didn't have a proper shower bar or seat, and we were able to help her order these. Her bed was lofted such that she had to get on it. So we were able to help have that lowered to more to ground level to avoid another fall hazard. So those were some takeaways from the visit, but perhaps the most striking takeaway was how appreciative she was for the opportunity to have a home visit, as it had been previously so difficult for her to get to clinic appointments. So this home visit and home visits generally are so different than clinic visits. You don't necessarily have your nurses and assistants there. You're not directly in front of a computer to look things up and order things. If you want portable labs done, you need administrative help to aid in arranging them. And naturally, you can only do a few of these in a half day. But at the end of the visit, I remember thinking how, with all this extra work that needed to be done to arrange care for the patient, how extraordinary this was and how above and beyond we seem to be going for the patient. But later I thought about it and I realized that the idea of going above and beyond to provide essential care for patients is really a misguided view of patient care and what we were doing. In order to achieve health equity, in order to allow this patient to attain her full health potential and not be at a disadvantage, this home visit wasn't above and beyond. It was the baseline that was necessary and something that should be standard and routine for her and for patients like her. And accordingly, it should be standard that we as providers are given time and resources necessary to fulfill our patients' needs, like this particular example of doing home visits when patients can't come to us. Making this happen obviously doesn't fall entirely on us as providers, but falls on the way in which we are reimbursed for our time, ensuring that it is fiscally feasible for us to do so, and the resources that we are able to utilize. For example, do we have easy access to home lab draw services, administrative assistants, and nurses that are trained in helping arrange these, etc. But I truly loved bringing back home visits into my life as a future PCP, and I think it's essential for certain patients and is something that we as PCPs can do to help many of our patients get closer to achieving health equity. And with that, that is my story. So thank you so much.
So my story is presenting just a general visit that I do when COVID first began. And my story starts off by talking about me at my desk, about to make a phone call to see a client. I'm thinking how much our interactions have changed. Normally, getting ready to leave the office includes getting my computer and additional paperwork just in case I have a computer failure. Now, incidentally, there's a bottle of hand sanitizer, but it's not generally used. Usually it's soap and paper towels, and that's satisfactory for infection control. When I make a visit to see a client, it's usually a cordial handshake at the door. But now what's disturbing for me are the clients that I schedule for a visit. It's not really a visit, but a phone call. And there are things that I never see anymore. How long does it take the client to get to the door after I've rung the doorbell? How long does it take for them to walk up the stairs, down the stairs? How many pauses do they have to take? Do they need any help? Are there any obstacles on the floor? Is the person short of breath? What is in their refrigerator? What are any supports in the bathroom to hold on to? Is the lighting adequate? How cold or how warm is their house? Are they unkempt? Are they unshowered? Are their faces sad? Are they happy? Are they showing understanding about what I'm talking about? Uncertainty? Really, what are their faces looking like? I'm now realizing how many things I routinely observe on a visit that I cannot see now when I'm making a phone call. How many clients are longing for a visit just to see somebody, anybody? They live alone, and so many of them are vulnerable. As I make this phone call, the things I no longer need really. I don't have to carry my bag up the flight of stairs. I don't have to travel. But now, no interactions. No interactions. The family members, the cats, the dogs, the furry animals, the pictures on the walls, the children, the grandchildren, the stories about their trips. You don't hear that anymore. And the stories that they share that go off on a tangent when a client talks about not being able to make the 1980 Olympics for the long jump because of the US boycott. Those little stories, those are the things I don't hear anymore. I'm straight to the point. Then the client will be talking to me about how she has worked so hard to look forward to her retirement and looking towards the fruit of her labor to see her grandchildren and the visits during the holidays. But now the abandonment is so painful, not even to see a nurse. The reliable visit she would generally see. She sits alone, all alone, waiting for the mailman. Maybe that's a good visitor, but when he comes, he rings the doorbell and he's gone. So she sits at home and watches the television and starts ordering a whole bunch of things so that somebody could just come and deliver a package and ring the doorbell. So she should just feel like there's a visitor, somebody. But as soon as they ring the doorbell, they're gone too. Well, how sad. How sad. She tells me, I think I'm losing my mind. I'm so frustrated about calling my son so many times because he's so busy. But then I just want to hear the grandchildren. He stops around once or twice a month to help take care of the bills, brings groceries if she should run out. He spends very little time. He never takes his mask off. He never takes his coat off. He doesn't even give me a hug, not even any contact. He says he doesn't want to make me sick, so he buys a computer so I can see the grandchildren on video chat. But that's not the same, she tells me. A hug, a touch, it means so much for me now. The groceries delivered at the door, and then they're gone. They just leave. So many times it feels like the walls are closing in. And I just wish that I could open the door and let the air exchange. I can't wait for spring to come when the weather warms up. They're telling me things should get better. I do hope so. I think taking a walk should make me feel better. But these calls, I say to myself, they're feeling so impersonal, like a collection agency, just calling and getting data to fill out the computer. I make a note of who is client I call. So many times they're alone, and if it's possible that somebody could be there for them. Well, I wonder, do things will ever get back to normal? So many lives are impacted. The essential workers, the aides that come to visit the client, the phlebotomist, the physical therapist, the occupational therapist, the speech therapist, the social worker. How do they do it? How do they all get together and figure out how to get in to see these clients? My role is not necessarily to see the clients, but on the other hand, I'm in the office. And all I do is we complete attestations so that we can be in the office. I pray, dear God, please don't let any of us get sick in this office. Now we can't see each other's faces. We can't see their smile or a smirk. We cannot tell if somebody is happy or sad. The faces are masked all the time. Now, Governor Cuomo is telling us that those that are 55 years and older with comorbidities, they need to get vaccinated. And right away, there's a buzz in the office because those who want to get vaccinated now with no comorbidities and are not 55 years and older, they're starting to feel slighted and upset. It's not fair. I don't want to take this home to my family. Then there are others who are saying, yeah, I really do want to get the vaccination. And it's such a hub. I ask myself, what's going on? Some are just saying this is all a scheme to get the pharmaceutical companies rich. But I want to know, will things ever get back to normal? Will things ever get back to normal? Or this is where it comes down to. It's getting now to early spring. And I think emerging through this now for a year, I think we could get it right. I think we will get it right. Will we get it right?
So I wanted to talk about two stories that I had way before I entered medical school. I worked initially as a scribe in an emergency department back in California, in San Jose in particular. And in the hospital that I worked at, it had an underserved population primarily consisting of Vietnamese and Mexican patients. And so to give context, pretty much half of the patients didn't speak any English. So this was a pretty disenfranchised population. And then there were two short stories. However, I'm a little bit shaky on the details since this occurred so long ago. And then at that time, I was still learning how to scribe. So I didn't really focus so much on like what was happening. I was trying to chart. But these instances were jarring to me. And I'm not sure if it was because these were particularly unfortunate cases or that I've somehow become so desensitized to some of these stories throughout my training, just naturally due to exposure. So the first one was, it was an undocumented family. They brought in their child, their baby boy, who just suffered a displaced upper extremity fracture. He was playing on a monkey bar set. It was obviously displaced even without any imaging. And then we had orthopedics come in. They reduced the fracture, splinted the arm to the best of ability, and then said that the patient needed to have surgery. So the emergency department attending was speaking with the parents about this, given the extent of the injury. And then when the mention of surgery came into the picture, I immediately saw concern on the parents' expression. And then I thought, okay, like this is an understandable reaction. Their child, their only baby boy, needs to have surgery now. But then in addition to that, I realized the shock on their face was also because they recently immigrated here, they're undocumented, and their child did not have any insurance. So they were asking questions like, was this surgery truly necessary? Is it possible that they could just bring their baby boy home and let him recover? And through the discussions, and we ultimately were able to bring social work into the picture, and the parents were in agreement to have the boy undergo surgery. And then I think in part was because the social worker was talking to them about potential payment options and financial assistance for all of this. So that's the first story. The second story, I remember it was like a late shift. This middle-aged, disheveled woman came into the hospital. She turned out that she had been coming in for malaise and she had increasing pain. And the pain turned out to be where she had surgery about a month out. And when we talked to her, she wasn't really able to give us any clear history. And as we examined her, we had her lift up her shirt, and then we looked under her shirt to see that her packing from 1 month ago was still there. And then I still remember that smell. That was like, at that point, probably one of the worst things I've ever smelled. And I was just in shock. This patient had this packing on for a month, and then now it's festering. And then when we removed it, it turned out the wound was even starting to dehisce a little bit. So I just don't know how it got to that extent. How does this happen 1 month down? So one thing that I do think about, since I am going into anesthesiology, is what must we do to prevent patients from falling through the gaps to this? We must need to develop a better and safer discharge planning, and then also be able to assess, does this patient have social support at home? Is there any way that this patient can take care of her or have someone else check up on her, if like, to prevent this type of issue? So as I was sort of writing this down, I want to use these two experiences to sort of remind myself that it's not okay to be desensitized to these situations. Patients are suffering, and then we really must use experiences like this and remind ourselves about that this is someone's life, this is not okay, and then use these experiences as an impetus for action. So those are the two stories that I have. Thank you for listening.
So I want to start up with a bit of an apology, because my story that I sent in, that doesn't really sound narrative in regard to a patient, but I want to say it is inspired by very formative encounters, painful encounters, and just I'm a rheumatologist. I specialize in scleroderma, but I got introduced to this ultra rare disease, Dego's disease, with a 17-year-old patient who had been diagnosed by the third dermatologist that he saw. And once they got the diagnosis, he and his parents went onto the internet to read up on it. And just the reading made them all devastated, because what was there were about 200 papers, 200 case reports, and they were all in the literature because they all were about patient deaths. And there wasn't any story of patient survival. And he actually felt quite well, just had these skin lesions. But within the space of a year, started having bouts of abdominal pain. He was a very stoical person. He was a soccer player. He was the goalie on his high school soccer team, and hard to read in terms of, he certainly kept a lot to himself. But the pain became excruciating, and he had a bowel perforation, with the finding at surgery that he had hundreds of these lesions on his bowel, which meant that he could have hundreds more perforations if he survived the first. And there was, at that point in time, no treatment. And we went on this journey, and we did find a couple of treatments. And it's too long a story, so I'm not going to talk about that, maybe a future slam. But and he had several good years, but he died at age 26 of further complications of this disease. So it's the arc of his life which drew me into the world of this disease. So so the work is not really a narrative work. It's really more of an advocacy piece. So I want to speak about health equity as it applies to those who have an ultra rare disease. And I speak from my experience, as I said, of serving as a consultant for individuals or taking care of individuals with this Kohlmeyer-Dagos disease. It's also known as Dagos disease or malignant atrophic papulosis. This is often a life-threatening illness which presents with distinctive skin lesions, but which in a matter of months to a few years can progress to catastrophic neurologic and gastroenterologic complications. Ultra rare in this instance means that fewer than 50 individuals are diagnosed with this disorder worldwide each year. So diagnosis is the first area in which equity is a concern. A dermatologist is most often involved, but in many parts of the world, dermatologists are very few and far between, with hardly any, for example, in sub-Saharan Africa, except perhaps for South Africa. So a sub-Saharan African with Dagos disease will likely never see a dermatologist and never be diagnosed. And indeed, there aren't any papers written about cases in sub-Saharan Africa. But even when there is a dermatologist involved, the diagnosis is often missed. An ultra-rare disease doesn't come to mind, and even a skin biopsy may be misread. Many individuals with Dagos disease have multiple stops on the road before even getting a correct diagnosis. Many are diagnosed only after an unexplained life-threatening event has occurred and long ignored or misdiagnosed skin lesions are reevaluated. In this instance, and I am sure in the realm of other ultra-rare disease, access to medical care doesn't mean seeing someone who can treat your hypertension or diabetes, deliver your baby, or remove your cataracts. Access to care may lead to no answer and no help unless one sees a provider willing to explore so-called zebras. Pursuit of treatment of a rare disease also leaves the individual at a great disadvantage. There is, in the example of Dagos disease, no FDA-approved treatment, no company working on such a treatment, though this may change. Progress often relies on patient advocacy, but there isn't the loud chorus of voices that can insist on change, as with breast cancer or HIV or ALS. What treatments exist include one of the most expensive of all medications, eculizumab, which can be a life-saving intervention for those with gastrointestinal Dagos. But obtaining a drug that costs more than $500,000 a year, requesting that drug for an off-label use, and making the request of individuals with no familiarity with the disease or its life-threatening potential makes for a nail-biting challenge for the patient and the physician. So equity means the hard to diagnose and the difficult to treat must have a means to find answers and treatments that come so much more easily and rapidly to those with more common ailments. Thank you.
So it's the night shift on pediatrics floors. As the medical student, I'm focused on helping however I can and generally being an enthusiastic sponge, absorbing the hospital and the information around me. We get a new admission, so we go down to Peds Emergency to see our patient. All I know at this point is that he's 3 years old, he's supposedly adorable, and has a rash. Earlier, he had a fever. Remember, this is pediatrics, and this kid is under age 4, so it takes some time and trust building just to get him to sit still so I can take a look. His mom is there too, and she anxiously tells me the story, answering my questions and lets me look at the rash. Nothing too concerning came up, but he was started on IV antibiotics already in the ED, so he was being admitted. Once they came up to the 3rd floor, I went to collect a more thorough history. It was then that I learned that his mom is pregnant, which wasn't readily obvious due to her obese body habitus. As I asked a few basic questions about their living situation, I learned that the man she had been living with was threatening her, beating her, and emotionally abusing. What could I say to her? She was scared for her life and the life of her unborn child. She insisted that he was not harming her son. I apologized for her circumstances and told her that she is safe here and she did the right thing by coming in, but my words fell so short. From a seminar I went to several years ago, I remembered that it's important to ask what kind of help a person wants and to never assume that anyone wants other authorities involved. If 2020 taught us anything, it's that the color of your skin means you live in a different world, a more hostile, more challenging world with fewer opportunities. I had not even heard the half of her suffering. She also has gestational diabetes, but had no way to check her blood sugar in her rush to leave their house. The nurse tried to use a blood glucose monitor, but she didn't have a patient wristband to scan. Additionally, the attending had concern for a pulmonary embolism. At the time, I was surprised to hear this. I thought, just because she's pregnant and nervous doesn't mean that she would have a blood clot in her lungs. But now I know better. I know that because she is Black and she's under constant stress at home, these adverse experiences make her at much higher risk for overall mortality. It is likely that she has had many other adverse experiences growing up, experiences that create chronic stress and can manifest as a serious medical problem. With her son safely in the care of the amazing Cohen's nurses, she went to the adult emergency department to be evaluated. The attending considered calling CPS to protect the child from the abuser, but he did not want to risk the child being taken away from such a devoted mother, especially considering he had no signs of abuse. I wish I could tell you what happened after that. I went home deeply saddened by her situation and honestly feeling guilty that I didn't help her more. The fact is that we provide the resources that we can in the moment, but there's always an entire floor of other patients to care for. It was late and she and her son were safe, but that wasn't enough. I'm here learning about advocacy work so that in the future, I can better direct these families to resources and support services that they need. With time and dedication to patient advocacy and policy work, we can change our world for the better.
So as I was thinking about a story to share with all of you tonight, an encounter that actually took place years ago came back to mind. At the time, I was a medical student assigned to the medicine floor of a very busy hospital in my home country, Dominican Republic. I remember being extremely excited in anticipation of all the clinical knowledge that I will gain there. I arrived every morning ready to tackle the day. And one of those mornings, I was assigned to care for a woman who had been admitted a few days earlier because of hypertensive emergency. And during our first encounter, I went into the room with my own agenda. I thought about the questions that I will ask her about her symptoms, the physical exam that I will perform, the points to discuss with the rest of the team, and even the medications that she will likely need on discharge. And as I introduced myself to the patient, who tonight I'm calling Maria, she led the conversation by asking when she could go home. I shared with her that we wanted her to go home as soon as possible, but her blood pressure was still elevated. I continued to talk to her, but she was visibly disappointed and frustrated. At this point, I also asked her about the medications that she was taking at home. And she shared then that she did not like taking any medications and that she will only take them whenever she had a headache that, to her, that was a warning sign that her blood pressure was elevated. And actually, as I spent hours during this and our following encounters throughout that week, I found out through conversations with her and her daughter how hard her life had been. She had struggled to make ends meet since childhood, and she can barely write her own name. So later on, by using illustrations, trying to conceptualize to her the impact of that her hypertension had in her heart, talking about the importance of taking her medications daily, and even suggesting how she could use her phone to help her remember when to take her medications, I learned something that is very important to me up to this day, and it is the importance of developing partnerships with patients and how enriching learning about their lives away from the clinic, or in this case, outside of the hospital, it is. And it would have been easy to blame her for being in the hospital without considering the many factors and reasons that, you know, may have led her to misconceptions about her condition and her need for medications. But taking the extra time as an opportunity to get to know her and to educate her, help improve her understanding as well as mine. And it is interactions like this that throughout my training and medical school and residency have helped me realize how in addition to all of the systemic changes that need to happen in the name of health equity, how our individual efforts provide care that meets the patients where they are adds to that common goal of creating a more equitable healthcare system. And that is my take on health equity. Thank you all so much for listening.
My name is Amber Davis. I've been working with Her Story for about 4 years now. Currently, I'm doing a lot of workshops. This particular Zoom is near and dear to my heart because me and, Janelle and I, we're doing the health justice workshop with Her Story. And it's just been very rewarding. And it's also just interesting to hear the doctor's side and the nurse side of it, because in our Stony Brook class, we're kind of just dealing with a lot of the students, right? There's psychologists, up and coming pre-med students. So it's always interesting to see where that love of medicine came from. So thank you, and I'll share my story with you guys. That click no one sees or hears, but you know that click may have not been what you needed to hear, but something that had to be experienced. That click that humbles you real quick and tells you to take a seat. Take a seat from your job, your daily activities, your family, and your friends. That click that makes you care about yourself. That click that changes your life. The click that tells you to sit down and listen. Sit down and listen to your body. Sit down and listen to what God is trying to tell you with all the things that are unfolding in your life. But too bad I cannot have a seat. No chair, no couch, no cushion can help me adapt to this new click. This click in my back caused by a driver's error in response, not looking while approaching a red light. The force that caused this click, the force that holds no one accountable for their reckless actions while using a deadly weapon. A force that has caused me to adapt to a new position, forcing me to stand up. Can you have a seat, please? I would rather stand, sir. When I sit down, it feels like a truck is on my hip. The doctor insists on me sitting and starts to touch the parts that don't feel comfortable. You seem okay, we'll give you an x-ray, but you really should hold on getting an MRI. Hold on. I guess he didn't hear me when I just told him I can't sit. He must not know my hip is on fire. He must have stopped listening when he saw me standing. He must have thought since she can stand, she's fine. They see me walking, so I must be okay. I guess they didn't hear me when I told them my pain level was unbearable. They don't see me crying, so I must be okay. But they don't see me when I'm alone at night, when all I can do is wipe away tears that soak my pillow. Why should I hold on? Are you trying to delay my healing? Healing that has been delayed, and now I'm the only one to suffer for yet another person's error in response. We stand so tall and strong through the pain, and we get told to hold on. Hold on to what, though? When we have to stand using our own 2 feet, feeling as if there is no one else to hold on to. Hold on to the hope that God will continue to give me the strength to stand. Stand up for myself, stand up for all of the Black women who get turned away by their doctors over and over turned away for appearing to be too strong.
I just want to share my sentiment that everyone's stories were beautiful, and I know I'm going to end this evening feeling a lot better about what we're doing in health, and hopefully we all learn that advocating for health equity is part of our role as being healthcare workers. And I don't know if anyone else has any comments, but this was a very successful story slam. And I thank you all for coming. And thank you to Northwell for collaborating with us and bringing your medical students and your program directors and participants. And also thank you to Her Story.